Welcome to Sips of Scrubs, a nurse podcast where we talk about the good, bad, and ugly of being a nurse. This is a safe space for nurses to come together and discuss our real world experiences with nursing, good, bad, and ugly. So, we touch on many topics here for those who are new to the conversation. I am Nurse Laney. I'm the host of this podcast. And today we are going to be sipping on Kiss My Legacy Perfect Pear. I've had it before in previous episodes, and I'm at this point really just trying to finish the bottle. You know what I'm saying? Because for those who know and those who don't, me and Jordan are going to start trying for a family. So I evidently I can't be drinking, you know what I'm saying? So I'm like, let me drink my stuff, because then I ain't gonna be able to drink it for a while, and then after I ain't gonna be able to drink for a while. So I'm like, let me drink the stuff I like while I'm here. You know what I'm saying? So that's what we're gonna be sipping on throughout today's episode. You guys pour up a glass of wine, drink some water if that's what you on right now, whatever you are comfortable with drinking, and sip along with me throughout today's episode as we talk about different stresses that we may encounter really in life period, but particularly towards nursing, since this is a nurse podcast. And we're going to dive into that a little bit later in today's episode. Did you know that fluids, including blood, can cause fluid overload for congestive heart failure in kidney patients? So I basically, did you know, I know us more experienced nurses, we may know that, or if you haven't been in bedside nursing for too long, maybe you forgot. When you're administering blood particularly, or really any fluids in general, just pay attention to your patient's history, because sometimes excess fluid can cause fluid overload, as stated in the did you know question. Because sometimes I think doctors really just be putting in orders and be forgetting what's going on with patient, or they may overlook something and made to put a less rate than what they entered. So as us nurses, y'all know we are the last line of defense. We're the last stop before a lot of times patient harm is taken. So if you guys peep that your patient's got kidney issues or have congestive heart failure or anything like that, definitely ask them hey, are you sure we're giving these patients this much fluids? I've had experience one time with one patient. They wanted to bolus, and they put a liter bolus, and then after I told them about the history, they actually wanted to do 500 mLs instead. So it definitely could change some things. So make sure y'all take that with y'all throughout y'all nursing practice if you didn't know before. And if you didn't know, kudos to y'all. Definitely drop down in the comments with some other facts in regards to things to look out for heart failure patients and kidney patients, so we can up our nursing practice. And now we are going to get into what would Lainey do. So on this, what would Lainey do? The nurse is asking and saying, her job just switched to 12-hour shifts, and she works the third shift, 11 p to 7 a, full-time CNA, CMA. So she's a CNA. My manager threatens to put me part-time because I can't work Wednesday. I have church from 7 to 8:45. I also give them 2 weeks notice so I can just do the job I'm getting paid for instead of the leadership position CMA I've been doing for 6 months and never got a raise for. Is there anything I can do? So it sounds like two issues going on here. So she is full-time, and her manager is threatening to put her part-time because she can't work Wednesdays. And then also she put in her 2 weeks notice for the job because she's doing other things that she shouldn't be doing. Well, she could do, but she's not gotten the proper compensation for. So I definitely would have a discussion with the manager and talk about these are my non-negotiables type of thing. And if they can't meet that to your preference, then I would quit. Simple as that. I think sometimes some people hold on to jobs longer than they need to. It's a two-way street. It's not only what they can do, I can do for them, but also what they can do for me. And if they can't meet my circumstances, then I may have to just move around. And you definitely should be compensated if you're doing things I don't want to say outside of your job description, because you have the qualifications for it, but if you up your level, you need to have compensation to go along with that, in my opinion. As far as the Wednesday thing, I don't see why they can't work around your schedule. I know in different places I've worked, people be in school, people got other stuff going on. If I'm able to meet my 3 day per week requirement, then it shouldn't matter which days of the week I'm working as long as I'm doing it. Like, that's how I feel about it. So I definitely would talk to her or him, the manager, and definitely tell them what your personal preferences are. And like I said, if they're not willing to meet them or make some type of adjustments, or y'all come together with a compromise, then I would pack up my bags. Simple as that. Y'all let me know down below what y'all would do in this situation in the comment section. But y'all heard what I would do. We gonna talk about it. And if you can't do that for me, then I'm gonna have to get up out of here expeditiously, as T.I. would say. So today's conversation card is, what's the craziest thing you've seen as a nurse? I don't know, like, there's so many things, right? It's something that amazes me literally every day. Like with this healthcare stuff, because I'd be like, girl, like, this is crazy out here. Why y'all people doing weird stuff? One of the craziest things that I could think of off the top of my head is kind of like wound care type stuff. I've seen patients where literally you can see inside of them. And it's like, doesn't seem like people should even still be walking around functional and be able to move around how they do or be oriented and stuff, with them having like holes inside their body. I just find it very amazing, because I'm just like, how did this happen? And it's not just like bedbound and confused patients it happen to. Sometimes I've seen patients who are like alert and oriented times 4 and ambulating, like they can walk. So it's just like, you didn't notice like you had something on your backside? Like, I'm not understanding. But I've seen like walkie-talkie type patients have bed sores too, and I just find it very amazing. And the craziest one I've seen, like I said, I could literally see inside that person's body, and I felt like I could put like my whole arm in there, like to the point you could see bone. So that's one of the craziest things I've seen as a nurse. If you guys want to share down below your experiences of what you've seen as a nurse, that's just absolutely bonkers, y'all definitely share that with us, because I always find these things quite interesting, the things that we see. Sometimes I've told people, like, I wish that my eyes had like camera lenses in it so I could just literally take pictures of the stuff that we see, because it's wild. It can't be replicated, duplicated. You can't talk about it again to make it match the severity of whatever was going on. So sometimes I just be like, I wish I could record with my eyes so y'all can see what I see, for like y'all regular people who aren't nurses out there. So, as I mentioned in the top of the episode, I wanted to talk to you guys about stresses that we encounter as nurses, internal and external. This conversation came about because I've actually encountered this in my personal life, and then I brought it over into my nursing career. So, y'all know, it's 2023. There's lots of different ways for people to be married or have relationships or whatever the case may be. Me and Jordan are pretty like traditional for the most part. I don't think we abide by the whole gender roles thing. Like, I feel like both of us could do like whatever. Like, I don't really take out the trash, but like I've put it outside before. You know what I'm saying? Like, it's not that big of a deal to me. Most of the time he's already on top of it and I don't have to worry about it. But like, that's just like a thing to say so that y'all can know what I'm talking about as far as gender roles, like chores and how stuff do in the house. Now, normally he does take care of more of the car stuff and things of that nature, and I do more of the housework, but he does wash dishes. He does very rarely, but he does wash clothes. He washed them recently, actually. And I was like, okay, I see you. But for the most part, like, I clean the bathrooms and things like that, and I cook majority. Now, so everybody does things differently. Do what works best for you. This is not an advice channel to tell y'all how to do y'all marriage. I feel like whatever works for y'all, and that's just cool, because you can't really speak for other people situation, I feel like, most of the time. So I just tell y'all what I do. So I was encountering, like, with the division of chores and things that we do, like, he works from home, I go to the hospital to work and come back or whatever. I realized that I place some expectations on myself that I didn't realize that I was doing at the time. And it wasn't that he was telling me that I needed to do these things. I don't know where that came from, where I felt like I was supposed to be doing something, but ain't nobody said that. And that kind of reminded me of some of the stuff that we do in our nursing practice. Like some of the pressures that we have and stresses that we encounter with nursing, we place on ourselves as nurses. Is no one telling us like, you have to do that, you have to do this. Like some things there are, but like other things there is not. So it made me think, like I said, about this conversation about stresses that we encounter, internal and external. It actually came into play like yesterday. I think like an infamous one is like people missing break. Like people be feeling like they too busy to have a break. And it's like, yeah, but no. Like, girl, you got to find some time. And I actually encountered that yesterday, and I hadn't felt like that in a minute because I've been in the ER for so long. I've started working back on the floor recently. And I had 5 patients this day, and like things were going on with them. I had one patient, I kept having to draw her blood every so often because her potassium level was low, and then they ended up placing her on a heparin drip and all this stuff. I had 2 patients discharging. I had a patient that was doing the CWO protocol for alcohol abuse, and I had to do like a telepsych consult for him. And then I can't remember my last patient, so excuse me, they must have been all right. I don't remember. I'm like, who was my last patient? Oh, I remember now. He like lung cancer patient. He was the most stable one. That's why I forgot him. Because his condition is not going to change. It's just managing symptoms at this point. So I actually really didn't worry about him too much. I did check on him every hour though, like we're supposed to for the most part. So those were my patients yesterday. And then I was thinking to myself, like, am I going to be able to take a break? Because it came to the point where like 2 of the patients were discharging like at the same time. And if y'all been working in healthcare recently, I don't know how y'all facilities are, but mine, like, they be pushing people like, okay, like once that discharge order in, you have only so many hours to like get it done. And usually on that unit, they have a discharge nurse, but this particular day, she was acting as the manager because the manager was out of town or something. So I didn't have that extra resource. So I was kind of like, okay, like I don't mind doing 2 discharges, that's fine. But normally it's not at the same time. And then for one of the discharges, I had to do stuff before the discharge in order for her to leave. So like her leaving at a good time was dependent on me. As far as like she was supposed to be on long-term IV antibiotics. We were waiting for a wound vac to come to her room to be placed on her because she was going home with that. And what else? It was something else that had to be done for her. But the antibiotics had to be set up outpatient. And then I had to make sure she got her line placed so that she could have the long-term IV antibiotics. So I had to call the doctor because at first I didn't see the order for the midline. But hey, when y'all get y'all patients back, make sure y'all go over the orders again because I did slip up in this area. The nurse I had gave report to, I got her, like she gave report back to me and she basically said there was no changes. But I didn't know because I didn't look through my orders at the time that they had placed an order for the midline to be placed. So I actually called the doctor and asked for the order and they had already put it in. Now they was real nice about it, but some doctors are mean. So definitely peep like your orders before you go calling to make sure, because that wasn't told to me in report. They said no changes. So I was like, all right, cool. And of course, like it didn't come up in my orders to be acknowledged because night shift had acknowledged it. So I would have had to go back through the orders and look through it to see what was there. But I didn't do that because I had her the previous day. So I already had all her information written down. But I had to get the midline placed on her. And at this facility, of course, you got to do the consent for the patient. And then they don't have a pick team on site. They like, I guess, contract people out. So I had to call the house supervisor so they could call the company so the company could come up and put the midline in for her. So that sounds like a lot, right? So I had to do all of that, get her connected to the wound vac, make sure she understood all that because she was going to have home health at home. And then she was going to be able to be discharged. Now, my other discharge patient, it was an easy discharge, but then they lived like not close by, like an hour away. So we were going to have to wait for the family to get there. So I was kind of like, it's always that like kind of like double dutch. Like, do I do it now? Do I do it now? Do I do it now? I was trying to see like, when am I going to take the break? Because I don't want to be, I don't like people taking my report for admissions. And I knew as soon as I was going to discharge them, I was probably going to get an admission. So I was trying to like anticipate that. So I like addressed everything else with my other patients who were not discharging to make sure they were caught up. But like with them two leaving, and then of course I take out the IV and all this other stuff. And then at this particular hospital, since it's small, they don't have transport. So somebody was going to have to be available to bring them downstairs. So I was kind of like trying to see when was the best time for me to go. It's kind of like a guess, like, is it now? Is it now? And I was like, dang, am I like not gonna be able to take a break because of the situation? And that reminded me of this topic of about the pressures we place. I'm not too busy to take a break. So what ended up happening was that I already went ahead and did their discharges. So I had them printed. So if one patient was to leave, all they needed was their IV taken out and to be wheeled downstairs. So I communicated that with the tech. And then the other one, I was like, I'll just wait till after to take care of her. But I already had the paperwork printed out. So I went on break, and lo and behold, when I came back, both of them were still there. So it's kind of like, can you imagine if I would have waited the whole time and I could have ate or whatever? Because I was thinking maybe this is one of them days where I eat and then like not actually take the break, but eat just to get some in my system, and then like stay on the floor, and then when there's like a good pause in my day, then go actually take my break. But I ended up just going ahead and taking my break, and I told the nurse tech, hey, if her ride gets here, she just needs her IV taken out. I've already done the discharge instructions and everything else. So that ended up playing out in my favor. But like I said, it kind of reminded me of this topic with the pressures that we place on ourselves and how we need to take time out for us to take care of us so we can take care of others. We hear that all the time, but we don't do it. And we need to do better about that, nurses. So no, you are not too busy to take a break. Delegate to somebody else. Go take your break and worry about whatever it is when you come back. I think the only reasons why you shouldn't take a break are like that may hinder you from taking a break is if you having like a very sick patient that needs to be transferred to ICU and they about to code or something crazy, like it's either a code or a rapid that's preventing you from going. But even on those days when I've had codes and rapids, literally after like they're transferred to ICU or wherever, whatever happens, whatever the outcome is, I go take my break after that if I hadn't already done it. And like if you still got to chart, just chart when you get back. I know a lot of times I think we don't want to like forget things or whatever. I mean, you could chart before you leave and then go on break. But the whole point is take your break, sis or sir. And like everything else can wait. Like them orders, the meds I learned during COVID, it don't really matter as much what time you give those meds as long as they given. Because I know we got the rule 1 hour before, 1 hour after. But hey, if other things are going on, okay, you got to do what you got to do. And if it's that crucial for you to have to get the antibiotic, most places now have a buddy system, or you got your charge nurse be like, hey, this person needs an antibiotic. Do you mind hanging it? I'm about to go on break. If it's that big of a deal. If it ain't that big of a deal, I'll say worry about it when you get back. A lot of times that's what I'd be like. I'm about to go eat, okay? And then I'll give it just a little bit later. An hour and 20 minutes late, okay, whatever. Not that big of a deal to me. And it ain't no, people coming back to clock you. Oh, I see you gave this medication 20 minutes outside of the hour window. What happened? Well, I was trying to figure out when I was going to take my break, and I was starving. So I mean, I don't think what they gonna say to that? Like, okay. So that's how I feel about it. I also can relate to this because I used to feel like as a newer nurse that whenever like orders were placed in, I felt like they had to be done like right away. I'm like so much better with that now. Like I'm like, it's not stat. Now if it's stat, okay, I'm gonna make sure it's done within 30 minutes. Or, as soon as possible. Most of the time I'm kinda can get it done timely. But if it ain't that, or if, like sometimes time stuff, but you already know it's time beforehand, like the Q6 checks with like people sodium or whatever, like that's coming. So just arrange your day around it. But for other stuff, it's kind of like, does it have to be done now? Like, is this going to cause patient harm if I don't do it right away? Is the doctor needing these results right now to determine care? A lot of times they don't. A lot of the times they be caught up in other stuff too, and they don't look at that stuff until the end of the day. If they look back at it at all, sometimes they don't look back at it until the following day. So why you over there breaking your back for some orders that ain't gonna be seen until the following day? I don't know. I'm just asking. Consider it. So that's kind of what I think about if I have things. And a lot of times I'll just like be like, okay, I'll do it when I go back into that patient room instead of like trying to struggle to do it now and make it fit with what I got going on. You know what I'm saying? Sometimes you are already in the middle of things and it's like you just came out that patient room. I'm not going to go back in there. I'm going to just wait till the next time I have to go back in there anyway. Or if I have the opportunity to go back in there, that's cool. But other than that, I'm not about to be stressed about this. So like I said, this episode is all about pressures that we put on ourselves as well. Because like I said, ain't nobody really coming behind you like, why you didn't do this, why you didn't do that, why you didn't do that. Now, those type of things, go ahead and do. But some things is us. So I want y'all to take this time out to reflect about the things that you place on yourself and what you could do to alleviate it so y'all not so stressed out at work. Because I'm doing better with the stress at work now. I don't mind as much. Like, I feel like I'm never going to be at the point where I'm like, oh, I want to go to work, but I don't mind going to work. And I think that's a good place to be in. So I hope that this episode caused y'all to reflect on some of the habits y'all may have picked up inadvertently and take care of yourself, because if you go be at this bedside game for a minute, like, you need to take care of yourself. You feel me? So we're going to go ahead and conclude today's episode, and we're going to scrub and sip. So today I am scrubbing annoying patients. So I had this patient and I felt like she was trying to like play games about being discharged. And I'm like, well, nothing's wrong with you. So what you tripping for? And it's always this, okay, this patient, she was trying to say she was a nurse, but I be feeling like some people be trying to say they nurses, but they don't be doing nurse like activity. I be like, if you a nurse, why you don't know how to operate the bed? And I didn't feel like she wasn't that old. I think she was like 30 something. So if you was a nurse, I'm like, were you really a nurse? Because why you don't know how to operate a hospital bed? I kind of see if people were older and they've been away from the bedside for a while. Technology changed so fast in medicine. So it's like, I can understand how you don't know some things. But like with her being that age, I'm kind of like, you should know how to operate these beds, ma'am. But she didn't know how. But anyway, when we was trying to discharge her, I already told people, like, when I do my first round and I know they probably going home, I go ahead and tell them, like, hey, just so you're aware, or like, do you know what the plan is for today? Have the doctor spoke to you about discharge? Like, sometimes I'll ask just to see what they know. And then she said no. So I told her, like, at 10 o'clock we have rounds and we discuss like the plan of care for the patients and get together, and we could tell like what an estimated discharge time will be. So I told her I'll come back in after the rounds and let her know what the plan is for her, because she said she didn't know. So I did that. And I told her that like she seemed to be doing better. They don't feel like she needs to be hospitalized any longer. So they're probably going to discharge you today. And I said maybe in a couple of hours. So she had the warning. But whenever the doctor rounded, she was like, I don't want to say making up stuff, because the stuff she was saying was like stuff that she had going on, but it was kind of like, it sounded like you making up stuff. So she was going through her My Chart, for those who use those at their facilities. It's like an app where you can see like your test results, your imaging results, and everything else. So she was going through it evidently and went and saw that on the, I think it was I can't remember if it's a CT chest to rule out PE or if it was a Doppler for bilateral lower extremities. I think it was the latter. So she was trying to say that on her results, okay, so it didn't say that she had anything acute. So for those who aren't familiar, acute means like this happened now or recently. It said that she had a chronic thrombosis or whatever. So that means you came in with that or whatever. So she was trying to ask the doctor, is it safe for her to go home with that in her, or like, you know, going on? And I feel like if you was a nurse, you should have known, like, it's cool. If they, all right, I don't want to say that because that might be not right. I was about to say if they discharging you, then they feel like you fine. But sometimes they don't be having the whole picture and they be trying to discharge people, and then we got to go behind them and be like, hey, like, I don't think this patient need to go home just yet. So I will say that. But if you was a nurse, you should know that chronic was fine. But okay, you could ask about it. But I guess maybe did you look at your my chart after the doctor came by and came up with this, or what? Or were you digging for information to come up with an excuse to be here? I don't know. Can't tell which one it was, but it just seemed like she kept making up stuff because then she kept wanting to talk to people after the fact. So I messaged the doctor. He came back up there, talked to her again about it, said it's safe for her to go home. Following that, she wanted to talk to guest relations before she left. And I'm kind of like, okay, I ain't gonna argue with you because I don't got time or energy for it. And the stuff people do sometimes just don't make sense to me. So I just be like, tell me who else you need to talk to and I could come send them to your room. And then honestly too, I ain't really want her to go home that bad anyway because like I'm gonna have to get an admission. But like I don't just be holding people and not discharging them because I don't want an admission either. Scott knows some of y'all out there be doing that. I don't do that. But I'm like, hey, make sure you comfortable before you leave. Because then when you discharge people too quick, they be trying to come back. And I'm like, nah. So she talked to guest relations and all this. Okay, wait, no, pause. Before she talked to guest relations, they tried to come in and talk to her, but she was working with physical therapy. Well, she said she wanted to work with physical therapy before she left. All right, cool. She did that. Guest relations left their number. Okay, she talked to guest relations. Then I was trying to discharge her because she's ain't no times four. She's young. Like, you know what's going on. You're a nurse, right? Then her husband calls and says he wants to be present at the time of discharge to also receive the discharge instructions. Now this lady, I know she was COVID positive, but like that wasn't part of her diagnosis. What did she come in with? I can't even remember now. It's 2 days ago. I can't remember what she came in with. I know she was COVID positive, but she was room air. I can't remember what she came in with, but she was fine. Oh, was it UTI? I can't remember what it was. I just know she was going home with antibiotics. Like, that's not that big of a deal. Like, what is there to be taught? Like, take your pill. That's it. Especially as a nurse. So then he said he wanted to be present at the time of discharge. All right. How long is it going to take you to get here? Oh, maybe an hour. Boy, what? Okay. I've learned in past experience, just go ahead and let them come up there because then I've had a situation where somebody felt like I was trying to rush them to be discharged. And I'm like, I'm not trying to do that, but this patient is fine. I don't understand why I just can't give you the instructions right now. But I digress. So I waited for him to come up there, right? Now he wants to go through all her home meds and see if they're the same ones she came in with. And okay, that's understandable because y'all need y'all meds or whatever when she go home. You don't want to lose anything. But it was in a bag that I guess he put them. Well, maybe the nurse put it in. I don't know. It was in a bag that was sealed. He over here he opened the bag, looking through all the bottles, looking to see how many in there. I'm like, all right. I just left. Call me when y'all ready to go home, and I'll come and take your IV out. So she was there. I think her discharge instructions were in at 10 o'clock, and she didn't leave till like 2, 3 o'clock because of all the requirements. I wasn't really tripping, like I said, because I didn't really want an admission. But I was just kind of like, okay, you could go home now. Like, you could go. But that's what happened to me the other day. It was getting on my nerves, but I tried to do the best I could with my patients. I know I'm working on my patients. I feel like I've been working on that forever. But I feel like y'all really be trying me at bedside with my patients. So I'd just be like, this is all I could do right now, okay? So I'm scrubbing that because that was annoying. But also, I really do need to do better with my patients. So I mean, I did good in that situation. I felt like I didn't come off like abrasively or like, okay, you need to hurry the F up. But still, I know I need to work on that. That's why I be having to like step out the room because I be like, I need to like decompress before I rub somebody the wrong way. So I'm scrubbing that for today's episode, and I'm going to sip to God knowing that I wanted to be back on the floor because I was sick of being in the ER. It's like every time I think something like, dang, I'm tired of being here. I wish they would assign me somewhere else. I don't even have to tell them. It just happened. So shout out to God because he be knowing what's going on. I was getting sick of being in the ER. I just felt like I needed like a little change. I was getting kind of, I don't want to say complacent, but I'm just like, I'm not an ER nurse. Like, okay. And then it's like ER is cool or whatever. and I don't feel like you technically work as hard, but I like it's a lot to keep up with because you're turning over patients so often. So like in one day I could see 10 people, and like some people I take care of like for 2 hours. So it's like I feel like I don't really do much, and it's kind of hard to like balance all of that. So I just needed a shift. And even like with the 2 discharges and possibly 2 admissions, that's still only 7 patients that I would have seen, not 10. Okay. So I'm sipping to God, knowing my heart and following through, because shout out to you. You lit. Y'all let me know now what y'all talk sipping to this week, and I hope y'all have a good rest of your work week. If you haven't went to work yet, if you're at work now, I hope the shit is lit. I hope it's a smooth shift. Ain't no coast, no rapids, none of the above. All right. And I'll see you guys in the next episode. Bye.